Welcome to the Rehab and Performance Lab, the MedBridge podcast where we dive into the world of orthopedics and sports. We're here to unpack the big topics, offering you practical insights and valuable tips from some of the most inspiring professionals in our field. Don't forget to visit medbridge.com to get your continuing education credit for this episode, plus access bonus resources. Hey everyone, welcome to the podcast. I'm Phil Plisky, your host. I'm a professor and author at philplisky.com and a high performance systems consultant with professional sports. Being a physical therapist and athletic trainer and strength and conditioning coach, we come at this from many different angles. We want this to be research-based, but more importantly, we want this to be practical and useful for you. I'm looking forward to our today's topic, which is joint hypermobility. I'm joined by Dr. Jenna Gourlay. She's a physical therapist and director of the orthopedic residency program for Rehabilitation Performance Institute. Welcome to the podcast, Jenna. I'm so glad you're here.
Yeah, Phil, thanks for having me. I'm excited.
Tell us a little bit about your background.
Right. So like you said, I'm a full-time physical therapist currently. I work in an outpatient orthopedic clinic. I actually started my career as a physical education teacher. And from there, I coached a little bit before going back to PT school. So I've always been in the sports world a little bit. Most recently, I'm an adjunct professor at the University of Evansville. I'm in the clinic and I see predominantly youth athletes and patients with hypermobility. However, I do cover the spectrum from young children all the way to aging active adults.
Oh, that's awesome. So you mentioned hypermobility. Tell us a little bit more about your passion for this topic and how it's kind of evolved over time.
Yeah, so I would say as I started out, right out of PT school, it was very, very small on my radar of things that I had to think about, worry about, look at kind of thing. And as my career progressed, it became more and more important and I got more and more interested in it. I would say it started, maybe 9 or 10 years ago at this point. And I specifically remember it even at this point in my career. I'll change as we go. I'll give, real examples, but I'll change the patient information to preserve HIPAA. But I specifically remember working with a youth volleyball team and I got all of these athletes all at once. So it was different than typically, seeing one patient here, one patient there. I got all of these young females all at once, all different things, and they were getting better, but not at the rate of the rest of the patients that I was seeing. So, I started questioning my abilities as a physical therapist. I started wondering what was wrong. And I will never forget this one day. I was working with an athlete that had shoulder pain, and she had a lot of restriction in terms of internal rotation. We're talking 20 degrees. And I was like, okay, I need to fix this. I can fix this. I have tons of things that I can do. And I remember trying dry needling and trying another soft tissue technique and rechecking with zero change and zero change with her pain. And I was like, okay, so you know what? I don't know exactly what to do right now. I'm going to do an arm bar. So I'm just going to do a little bit of scapular stabilization. I did that and immediately her motion changed.
Wow.
And, yeah. So as I started working with these athletes, I started noticing that a lot of them had differences that I wasn't used to seeing. And there was a huge change in terms of what their joint mobility or what their motion was like compared to typical patients.
So with that, okay, you're seeing a pattern, you're seeing, kind of things being a little bit different, especially since you have a group of people that you can kind of compare to, right? Sometimes when we see one patient, one off, but is there anything in the research that says, hey, this is something important to look at? Why is this important in our clinical practice?
Yeah, so as we look more and more at the research, it's actually getting more and more prevalence and it's gaining traction. Up until 2017, we didn't have a great diagnostic criteria and we didn't have a lot of kind of cohesiveness in terms of what we were looking for. And now since 2017, we've gotten a lot better at it. So as we go, we're seeing the ability to have these patients get a diagnosis or at least know what to look for in the clinic. So as we're seeing these patients that have a lot more maybe joint mobility than our typical patient, we can start to kind of put them into a different category than what we might put somebody that's, more typical. And I think, maybe talking a little bit about what hypermobility is or what joint hypermobility is for our patients too.
Let's hit that right there. I mean,
Hmm.
because I think when you traditionally say the word hypermobility, we are
Hmm.
thinking, patients with a high Beighton score, and they, people are palming the floor, doing party tricks with their shoulders and elbows and things like that, and that's kind of an extreme version of hypermobility. What does the current research kind of say about what are we actually talking about?
So when we are talking, everything is kind of along this spectrum now, the hypermobility spectrum disorder, HSD. And it starts from actually asymptomatic. So those are our patients, maybe, that just have a lot of flexibility, like you're talking about, quote unquote, double jointed. Those are the ones that can move into extreme ranges of motion, but they actually don't have any problems. And that's okay. That's not a problem. We don't need to necessarily fix that. When we start looking, though, along that spectrum, you can be anywhere, from localized hypermobility, where it might just be one joint. So think more like multidirectional instability of your shoulder or hyperextension at your knee. And that can kind of go along that spectrum to generalized hypermobility, which is more that, high Beighton, where you're 5, 6, 7, 8, 9 out of 9 in terms of on that scale, all the way into Ehlers-Danlos.
Okay, so I think one of the things I really want people to take away in hearing you talk there is it's not just the extreme cases of hypermobility that maybe we were taught in PT or athletic training school. It's beyond that. It's kind of staged. It's got a, like you say, I think spectrum is a great way to describe it, because you could have different degrees, different severities. Is that what you're seeing in clinical practice?
Yeah, that's what you'll see a lot. And just because somebody has like more hypermobility or more movement, say, doesn't necessarily mean that they're, worse than somebody that just has it at their shoulder or something like that. But you will see different degrees of this, where you might see somebody that can, has hyperextension at both elbows, both knees, their fingers, they can palm the floor. And then you might see somebody that just has a ton of motion at their shoulders or at their knees. And again, we have like localized, which is usually one or a few joints. We have peripheral hypermobility, which is usually hands and feet. We have that generalized, which is that high Beighton. And then we also have historical. So people that may have presented that way earlier in life, but now they're, fifth, sixth decade where some stiffness happens, or maybe they've had surgery where they don't present the exact same way, but they previously did.
They previously had mobility, and now life has kind of, as a connective tissue, kind of, and the collagen kind of, loses its elasticity.
Yeah.
They might look more like a normal mobility individual versus hypermobile as they get older. So what I'm hearing is that you could be both hypermobile throughout your whole body, but also just some specific joints like shoulder and knee, for example, and have localized hypermobility, and the research bears that out.
Yeah, it does. And it's getting better and better as we get better at classifying these things too, because a lot of our research, if we look like, early 2000s, even 2010s, it was like a lot of different research was defining things differently. So whenever you have that, it makes it a lot harder to kind of get solid research or replicate it in other ways. But it has gotten better. And because of that, we're seeing a higher prevalence, which, you can't necessarily argue that it's all of a sudden more prevalent. Are we just finding it more?
Right. Yeah. So that's part of the problem here is as we look at just mobility in people in general. I know in professional sports, if you would have asked me 15 years ago in, let's say, baseball or soccer, for example, that, when you looked at someone's thoracic spine mobility, that I could almost guarantee that they would be limited. I could go to Vegas on those odds and be right without even testing them. And I would say in the past 5 years, we've seen it flip. We've seen it now. I know you do a lot of work in professional sports as well. What's your experience there as far as what the general trends of athletes are in mobility?
Yeah, it's interesting. I mean, I feel like as I've, gone through my career, I feel like I'm seeing less and less true mobility problems. And when I say true mobility problems, I mean the ones that, you really need to get those manual skills and you need to, start trying to mobilize or manipulate a joint. Like, I'm not seeing that as much. I'm seeing athletes that, or, active individuals, people in general that have great motion, but then also have pain. And I think that's what was really hard for me at the beginning of my career, because I didn't have like a box for that. I was like, well, you're telling me that your shoulder hurts, but you have like 10 degrees more
I have
than
nothing
most
to
people I
mobilize here.
see.
Yeah, I have nothing to mobilize.
Yeah, and nothing's coming up on MRI and nothing's coming up on X-ray, and I just don't have a box for that. And as time has passed, it's like I'm starting to see, okay, maybe that's actually more from that hypermobility or that like multi-directional instability type thing, where you're having pain because you have so much of that motion, but it's quote unquote unstable, or you don't have like the motor control to really control the motion that you do have.
Well, and probably to confound it even farther is these patients frequently come in and say, could you stretch me? My shoulder's tight. My hamstrings are tight. Can you stretch me? What's going on there? Like, I mean, because you see it all the time, and then you almost like just do something and it just clears up right away. And you're like, wow, that really can't be sarcomeres decrease there, can it?
Yeah, and that was tough because, I'd have a dancer, let's say, that had 120-degree straight leg raise, and she's complaining of tightness in her hamstrings. I'm like, no, those aren't tight. But what she's feeling is quote unquote tightness. And what could that be? Well, that could be in somebody that, let's say, has a lot of range of motion at a joint, but doesn't have the stability that they need. Well, that could be hypertonicity. So that could be a lot of the more prime movers creating a little bit of artificial stability instead of the stabilizers that should do it. It could be some neural tension trying to create some more of that stability. It could be
so let's pick that apart a little bit there. You're saying neural tension. So if my nerves don't elongate well enough through my available range of motion, my body's going to lock down on that?
Yeah, they could. And it's kind of like there's some research that shows that there is a lot of times more neural tension, like upper limb tension tests, let's say, in patients with hypermobility than patients that don't have it. So, is that neural tension trying to create a protective mechanism for that joint that can move a whole lot, and maybe the motor control is not there. So the body's trying to do whatever it needs to do to either A, control motion, or B, stop motion in some cases.
Well, absolutely. It makes a ton of sense. If I have a lot of mobility at a lot of different joints and you take me into an upper limb tension test, the first tissue that might provide some restriction might be neurologic in nature. Wow, that's awesome. So, all right. So we've kind of, I will say we've maybe expanded our definition here, that we're not just talking about people with, a high Beighton score, but how do we go about, from a research-based perspective, diagnosing these people, identifying these people? Because when I think of like Ehlers-Danlos syndrome, I think of that as a diagnosis, and you kind of know what you're going to get, and you have a pretty good idea. Well, maybe we'll talk about that later, but pretty good idea of how to treat that. But you're saying that it's just not that simple.
Yeah, and I mean, even Ehlers-Danlos, there's a large criteria that you can look up online that you have to hit multiple things in order for, a physician to be like, okay, yes, you do have this. Because when we're talking about Ehlers-Danlos hypermobility type, there's no genetic marker for that. So for the other types, there's a genetic marker that can point to that. For hypermobility, EDS hypermobility type, there is not a genetic marker. So there is a criteria. But even so, we still have that hypermobility spectrum disorder. So how is that diagnosed? Well, one, again, if it's going to be a disorder, that's going to be somebody that has pain, or it doesn't necessarily need to be pain, some sort of secondary musculoskeletal issue. So it could be pain, it could be like
dislocate or feeling of giving way, that type of thing.
Subluxation, dislocation, like overuse in terms of like tendinopathies, things like that. And then you can use Beighton. That's one of the most accepted ways, but even that has its limitations, and we could get into that. But your clinical judgment is going to come in there. Like, what do you feel at each joint? What do you feel about at the joint surrounding? How does one side compare to the other? Because you'll see baseball players, that have a ton of external rotation in their throwing arm, but maybe don't on the other side. Or you might see somebody that has a ton on both sides, and that's a different individual in some cases.
So let's go with some known things, and then let's explore maybe how we can look at some things in a different way. Can you review for us what we're looking at when we keep saying Beighton criteria and what that means?
Yeah, so Beighton criteria, we have, can the pinky, can that get past 90 degrees? Can we bring the thumb to the forearm? And we're doing
There
these
you
on
go,
both.
and just doing it right now. If anybody's not watching on video, Jenna just put her thumb to her forearm.
Yes, I do have hypermobility to some degree. So, and you give a point for each side. This is out of 9 points. So you have two for pinkies, 2 for thumbs, 2 for hyperextension at the elbow, each elbow, 1 for each knee, and we're going more than 10 degrees of hyperextension at the elbow, more than 10 degrees of hyperextension at the knees, and then can you palm the floor? So if you're standing, feet, don't bend your knees. Can you get your palms to the floor?
So what would be considered, maybe historically or traditionally, what would be considered yes, I am a hypermobile person based on Beighton?
Yeah, so for the most part, like in terms of like post-pubescent to middle-aged adults, like the research will use 5 out of 9 in terms of like classifying generalized hypermobility in that sense. If it's a child, then 6 out of 9 or more. And then if it's an older or aging adult, then usually 4 out of 9. And then there's some other things you can look at as well.
So that's a really good starting point. That's kind of, if we use the old traditional stadium analogy, we got into the right stadium at this point. We know we're dealing with someone with mobility and hypermobility, but maybe can you give some examples of someone, what their classification would be that maybe didn't have 5 out of 9 or more on a Beighton? Is that a thing?
Yeah, so that would be like that 5 out of 9 is really for that generalized joint hypermobility. So that's kind of like that more or less like throughout the body type thing, versus like somebody that maybe has localized or something. That might be somebody that just has greater range of motion. Like if you take the shoulder, for example, have a whole lot more external rotation and then still have a lot of internal rotation, or somebody with hip motion. It might be somebody that does have, that leg raise that is to 120 degrees. And it could be other things too. Like the Beighton is looking at different parts of the body, but then there's other signs that somebody may have hypermobility too, like a really flexible foot, pes planus, flat foot, problems with the jaw. It could be things like if you do have previous subluxation, dislocation, especially that are not necessarily caused by like a fall or something like that. These are all kind of clues that make you start thinking, okay, is this person more trending towards hypermobility than not? Same thing.
So
like,
it's beyond just a 5 out of 9 Beighton scale. You can have it a lot of different ways.
You can, and I think knowing the Beighton and using the Beighton can help you. It'll still help you with a ton of patients. There are just still going to be patients that maybe you miss, but again, you're still going to get a whole lot more than if you didn't check that.
Okay, so let's talk about those characteristics. You said, okay, joint subluxations that are atraumatic, right? So if I think of almost that old classification of Ambry and Tubbs for our shoulder, right? An atraumatic multi-directional instability, that would almost be like a point on the scale, if you will, right? Like that's kind of leaning me toward that, a particular joint hypermobility. So, beyond 90 degrees of external rotation in the shoulder plus 60 or more of internal rotation usually. And so that would be an individualized joint hypermobility combined with, some instability there, that straight leg raise of 120 degrees. Yeah. It begs the question, I think of dancers and things like that, there's got to be somewhat of, certainly a genetic predisposition for people who have more mobility to probably be more successful in that sport than people who like that are just generally tight. But then that sport also prizes that mobility. So they're taking their genetic expression and the phenotype then actually gets expressed even more because of their environment. Talk me through that kind of concept. Like, how does that work? Like, is it just these people go into that environment, they're already that mobile, or what is it? How does that work?
Yeah, I don't think it's so black and white where it's like one versus the other necessarily. But it is interesting because obviously you do see a lot of commonalities in, dancers and gymnasts and a lot of sports that, do kind of prize that added hypermobility. And again, we're saying, like, when we're talking about this, we're talking about people that have symptomatic hypermobility, because there are plenty of people out there that have hypermobility and it's not a problem. If you don't have pain and you don't have subluxations and you don't have soft tissue problems or some of the other things like fatigue and that sort of thing, you can be hypermobile or have hypermobility and be totally normal, pain-free. That is a possibility. It's just when you do have hypermobility, it does put you at a little bit increased risk of these things.
All right. So let's say I've identified this person as, I like to use the term increased mobility. And, it's that you've identified that they have more than normal mobility and they have more than just one thing. It's not just saying I've got a lot of shoulder external rotation, right? It is a cluster of signs and symptoms. They're having pain with it. We just kind of went through that.
Yeah.
Once I've identified that person with increased mobility, maybe by biting too, what does the research tell us that they in general have as characteristics? What does that look like?
So there are characteristics, there are findings that kind of go along. It doesn't mean that if you have hypermobility, you definitely have this, but there are a lot of things where if you know these things and you suspect that your patient has hypermobility and you're like, hey, do you constantly feel like you want to sit all scrunched up or with your legs crossed, or you are the one that like finds a weird position on the floor, that's buy-in very quickly, because they're like, how did you know that about me?
Right.
So let's talk about some of those characteristics, because one, they are interesting. Two, they help get patient buy-in. And three, they do help you start to put people in some boxes. So characteristics that you'll often see are, again, people that kind of get into weird contorted positions that other people would look at and be like, how are you comfortable there? People with hypermobility sometimes will bruise easier. So you might see that. There are other
Do we know why that is?
Well,
I'm
it
just
is
curious.
like depending on where you are and everything. Like, it is a connective tissue disorder, so sometimes it is a little bit of that, and sometimes it is another thing that we're going to talk about, which is impaired proprioception. So like not quite knowing where exactly you are in space. So for some of these individuals, even if they're athletic, they may still say, I'm clumsy. I like run into the side of a wall, or I hit my leg on the desk every other day. Or a lot of times they just have bruises and they're like, yeah, I don't know where I got that from. That is very common with this population.
So that's even something you can look for as you're evaluating the patient. Anytime you see a bruise as a healthcare provider, you're always asking about it, anyway. But if it's just like, you see this, I usually see it in the thighs and the back of the arm a lot. I don't know why in particular, but and sometimes the calf. But you see that and you go, how'd you get that? And if someone's like, I just woke up and it's a pretty massive bruise, isn't it? I mean, it's not just like a little, no. You would have to the average person would have probably noticed that they did so. Oh yeah, I got hit by a baseball. Oh yeah, I ran into a doorknob, something, but they don't see that.
No. So it is always, sometimes they know, sometimes they don't know, but most of them will be like, oh yeah, I bruise easily. Like they just know that about themselves. Again, this is not research based, but just from experience, there's a lot more patients that are ticklish. They're a lot more sensitive in terms of certain touches, like deep compression and sustained pressure and things like that are okay. Their body can relax. But if you're like poking and prodding or like moving or changing your pressure, a lot of times that they will tense up a little bit more. So again,
it almost reminds me of sensory processing issues that we see in younger kids, right? That that deep compression, that axial loading, that feels good, grounding compared to it's probably what they're doing, and they're sitting and kind of balling up and stuff like that. They're grounding themselves because they don't have the normal proprioception.
Yeah, that and liking that compression, that is in research. So like deep compression, you'll see can help with some of the pain and also some of the proprioceptive issues. Also taping. Taping's a big one that sometimes helps because again, it's just giving feedback into their system where they do maybe have a little bit less proprioception than the next person. But now you put this tape on and all of a sudden the brain goes, oh, that feels nice. I kind of know better where I am in space, and then they can perform better or feel better.
That's awesome. What other things do they typically present with?
Again, like with kids too, they'll walk hard sometimes. Like they just put a lot of force into the ground. I think it's along the same lines as like that proprioception. As you get into like more generalized hypermobility and EDS, atrophic scarring, so where they scar, but it goes kind of like lower than the rest of the skin, something that you might see and you see quite a bit. And again, like with that, sometimes GI issues, generalized fatigue. We're talking about other systems here. Once we get more towards that EDS end, you can see it with hypermobility as well. It's more common once you get to that EDS.
That's interesting. All right, let's translate this into the clinic now. We've talked a lot about research. We've talked about the presentation. Are there certain patients or conditions that we see this with, or how does this play out?
Yeah, so I think one of the ways that it definitely plays out is when you see it and when you recognize it, you know that they might present a little bit differently. So we just talked about like some of those just presentations, but the big ones that you will see are that one, decreased proprioception. So just not having the best awareness of where they are in space. Like this might be a person where you're like, don't lock your knees. And they're like, I'm not, but they're in 20 degrees of hyperextension. And you're like, okay, right. We might need to change where that is. It's also a person that will hold tissue tone, so that hypertonicity, but they might not be tight. So that's an important differentiation, right? Like you said before, like we're not changing sarcomere length. So if you're, let's talk manual treatment a little bit first maybe, and then kind of go down the line. But with manual treatment, again, everybody responds to different things. So this is not like, it's PT school. It depends to some extent, but there are things that are context matters. Yeah, there are things that are more helpful than others. So, in terms of like any kind of manual, like deep compression where you're not changing how much pressure you're providing helps. Like a rhythmic stabilization or PNF is really good in terms of helping like decrease some of that tone surrounding the joint. Giving like more stability at the joint actually can help create some of that decrease in terms of that hypertonicity. So again, like where we might do joint mobs on somebody that's, lacking internal rotation or something like that, we might do more rhythmic stabilization, PNF, or even like contract, relax, isometrics that actually help bring that tone down. Because a lot of times the tone that you see is not necessarily a restriction. Again, you alluded to it before, like sometimes patients are like, oh, I just want to stretch. And that's a conversation that you have to have with your patients because they're not helping themselves by stretching if it's not a muscle length problem. And it's usually not in this group.
So can you walk us through maybe, a presentation or a history of a hypothetical or an anonymous patient that what would this look like in an evaluation type thing that would, boy, this is really something here.
Yeah, definitely. So like for example, again, I'll change some of the information so that it's not it doesn't give away any information about patients, but let's say there's a patient and it's a middle school athlete, a soccer player that has low back pain. And this patient, she just continually complains that she does have tightness in her hips. But you look at her hips and she has, 60 degrees of external rotation, 60 degrees of internal rotation, and 110 degrees of straight leg raise. Hip extension, Thomas test is fine. All the motion is fine. But she has pain there and she says that she has tightness. Well, you can go in and you can do soft tissue like you would for somebody else. And sometimes that will work and that's awesome. And then they feel better. Other times, this is a person that maybe has some quote unquote tightness or feels that tightness in their hamstrings because it's protecting lack of core stabilization, right? So let's say I've done this. Let's say I was with a patient and I was like, okay, well, she doesn't have a restriction in her hamstrings, but I'm still going to do some soft tissue because that's where she's feeling all of it. I can take some of that tone away, but if I haven't done anything to help with that core stabilization, it's either A, going to come right back, or B, actually sometimes make things a little bit worse. So for that,
go
ahead.
With that, so I think I got to pause there for a second, because what you're saying is, you find this restriction in the tissue, or maybe you find a restriction in range of motion, and one of the telltale signs is that they might feel better momentarily or in the session, but then they come back not feeling better, or maybe even worse.
Right. And
what I'm thinking about there is, how many people does that happen to when you're quote unquote you're on the right thing and you're treating the impairment you're finding, yet they're getting worse, and we tend to want to blame the patient, or we, they did something,
or I'm like, my manual skills aren't that good, or something like that,
or blame ourselves, right? Yeah, but I think that's pretty common, which probably goes to what we talked about earlier in this conversation, is that it's underdiagnosed, underrecognized, just even underrecognized as far as these are the signs and symptoms that someone might have this increased mobility.
Right, and if you don't check, or you don't know whether or not they have hypermobility, then you may assume that they are not getting better when it's just maybe incomplete. Maybe the soft tissue to the hamstrings is great because now we decrease some of the pain, and the patient's now going to do better when we go into lumbar stabilization and we go into some of the core control and things like that.
You've got to put the stabilization on top. So if you're going to, so it doesn't mean it's necessarily a bad thing that you're addressing that tissue, but boy, if you don't give the joint stability with it, then it could be.
Yeah. And I will say, so soft tissue, usually not a bad thing if it's paired with stabilization. However, usually with these patients, unless they've had surgery or something else, like getting them away from overstretching is really challenging, but very necessary. Because again, they have the motion. Whether or not they feel that way or not, they're probably just stretching more and more into like that laxity in the joint, where again, they might feel that relief for like a second.
Yeah, they get the endorphin relief from it.
Yeah, because they just feel something endorphin different, release, right?
Yeah,
they feel a different perception than like, this discomfort, but then it can come right back, or even come back at a later time to a greater degree.
For sure. So to keep going on this soccer player. So what does this look like? So
for this individual, I actually didn't really do much manual treatment, which is sometimes my first play, because if I can show them these are also individuals, which we didn't mention before, but these are individuals that often see 8 to 10 different providers before they're given a diagnosis of hypermobility spectrum disorder. Or these are people that have had symptoms for a while in some cases, where if you can give them relief without too much manual treatment, that's a really good thing. So if I can, sometimes I'll try that first. So this is an individual that feels really tight in her hamstrings, like she does her 110 degrees straight leg raise. But I do some lumbar stabilization. So trying to actually just teach her where like lumbar neutral is, which sounds very simple. And it is simple, but it's not easy for this population, because she's hanging out in, a ton of lordosis. And she's like, no, this is neutral. I take a picture.
And I come 5 degrees off of that, and I'm in neutral. Yeah. And you're like, you're still in 20 degrees lordosis.
And that in that case, I almost always say, can I take a picture of you? Take a picture and show them. And they're like, no way. There's no way that's what I look like. And I'm like, it is. That way, I just took that. Like, that's what you look like.
I didn't make this up. Yeah.
Yeah. So for this individual, we worked on that lumbar stabilization, finding where neutral was, working on like a posterior pelvic tilt. So honestly, just getting into lumbar flexion, which was very challenging for this individual. Did absolutely nothing to the hamstring. So she was in either hook lying, supine with her knees up, or quadruped, working through that lumbar flexion, working through finding neutral, and maybe doing like a push or a pull or something with her arms while she maintained that. And then after that, I always have the individual stand back up, do whatever they felt like hurt or felt tight or whatever, and then see how they feel. And in this individual's case, like that immediately, she was like, oh, I feel so much less tight. I'm like, perfect. We did not stretch and we did not, push your leg over your head or anything like that.
Right.
So that's what I want you not to do at home. And that is a conversation that you do over and over and over again.
Right. It's a hard habit. It's kind of like someone cracking their knuckles. It's just, it's that endorphin release that, what do you mean you want me to stop doing that? It feels great, And, so tell me about, like, how does this, like you said, this came about with the volleyball team, seeing these kind of trends where we had this increased mobility. Are there other examples that hit can give our listeners an idea of what I should be looking for to help me identify these people? Because one thing I hear too is I don't even necessarily, and I don't know that you were saying this, but I don't want to attach the label to them of hypermobility spectrum disorder necessarily, right? If someone's got, a hypermobile shoulder, they're, they're an Ambry type patient, they have hyperextension at the knees, and they can palm the floor, but they're really not far along this. I don't know that I want to label them that way, do I?
And especially because a lot of times you might see somebody that, again, doesn't even score high on Beighton, but they still have some hypermobility, like you're saying, at some joints. Or maybe they have 5 degrees of knee hyperextension, but not the 10 degrees, so they don't get the point. But in that case, I do still explain to patients, like, everybody is kind of on, this continuum of, you're super stiff or you're kind of more loosey-goosey, and you're trending more towards that loosey-goosey end. And that's a great thing, especially if, they're a gymnast or things like that. That can be a big advantage in sports, in life in general. With that comes a little bit more responsibility, though. Because you have more range of motion, then maybe the person that's right in the middle of that, you now need more motor control, or, talking to a patient, you now need more ability to control, to coordinate, and to be able to stabilize at those joints. That's what we want to work on.
Now, do you find that these patients tend to have a longer course of care or multiple injuries, or, what does that look like? I mean, I think I've found that, but I'm just curious what you see there.
I think initially, so like if this is my first interaction with this patient, it's going to be a little bit longer than, somebody that's more in terms of like being typically mobile. It is going to take a little bit longer because we're teaching different positions that they may not be used to. We're kind of undoing that like self-stretching, self-manipulating that has been their go-to to give them 5 minutes of relief. And we're kind of like reprogramming how they kind of approach the care of their own body. Like, I want them to be empowered so that, if they do get that shoulder pain after they do 200 tennis serves with their coach one day, that they're like, okay, I have these go-tos that I can do and I'm going to be okay. But I think as we look at that, like, we want everybody to be able to do it on their own. So we don't want them to be reliant on us, but that initial one is typically longer. And then, yes, I do usually, things pop up. They'll come in, a couple of visits, get it calmed down, get them back on their self kind of management program type thing, and then go from there. I'd say the first visit is longer, and then subsequent visits are actually probably shorter, if we have a flare up or something different happen.
So that course of care can be shorter once you've educated them. One of the things I think of, when we think of a pain neuroscience education, when, we think of getting that high quality interaction with the patient, one of the things I hear in what you're saying there is obviously education is essential to this. But one of the things you mentioned was, I want to teach you how to, kind of in that pain neuroscience education of like, this is what pain means in your body. Finish that teaching explanation for me there, how you would go about what does, because you're going to, I would imagine, let's say we're halfway through our course of care and they're feeling great, they're feeling awesome. And you're kind of going, all right, now there's things that are going to be coming up in your future. How do you know when to see me? How do you know what to
Right.
do when things happen?
And that's a good question, because one of the big things is not to give fear, right? My whole point is to empower them. So like to be like, you're going to have a problem mid-season because, the training's going to be so hard and the load's going to be so, like, that doesn't help anyone. And
You're
that's
setting them
not,
up for failure. Right.
that's not true. But the conversation is always like, our bodies are constantly changing how they feel. When you have this increased mobility, a lot of times you will fluctuate maybe more than the typical person. So there might be days where you feel that tightness and you're probably not tight, but maybe you are, or those days where you feel a little bit more pain or where you feel like your body just doesn't feel as coordinated. That's okay. Like, that's not necessarily when you need to see me, because we've given you X, Y, and Z, and you're going to go try those. Make sure that, you go through them, give them a little bit of time. If it continues, that's when you come see me, or if you have an injury or something like that. But again, we all kind of go in and out of, maybe discomfort to pain to fatigue. And it's more about knowing what to do when you feel these things than it is like, oh my goodness, something is really wrong with my body. So usually I give people I give them their go-tos, and that's what they'll kind of run through. Did you do anything that was an injury? Like, if they sprain an ankle or like they landed weird or something like that, that could be traumatic. Like, yeah, you can come in and see me. But a lot of the things that kind of pop up for this population are things like, I don't know, my shoulder started hurting or my knee started hurting or my ankle started hurting, where it might be
kind of like those bruises, I didn't do anything that I remember.
And again, like, these may be the patients that like at one time would have like confused me a lot, because it's like one day their shoulder hurts, the next day their neck hurts, the next day their hip hurts. And it sometimes changes.
Well, and that can also cause us to put people in inappropriate buckets of like, they're malingering, or they have some sort of psychosomatic disorder that is
right. That's not
causing
the case
their pain.
here. So
that's important for people to hear. I think that's a huge thing, because I think when someone comes in with shoulder pain one day and knee pain the next day, you as maybe a traditionally trained rehab professional, you're like, well, that doesn't happen without an injury.
Yeah.
You're kind of saying it does.
Yeah, it does. And it's also like helping patients recognize scenarios that might cause it. So like, we've talked a lot about athletes. Let's just shift real quick to like a normal kind of population. Let's say it's somebody that has hypermobility and maybe goes on walks and does every typical ADL or everyday type things. That might be a person where I want them to know that, if your activity increases a ton, that might change what you're feeling. And I don't want you to be worried about that. Let's say you guys go on vacation and you do a 3-mile hike when you haven't hiked in a while. Your muscles are going to get very tired. When the muscles get tired, sometimes you get a little bit of that instability or a little bit of that feeling. So your muscles surrounding that joint tighten up. Then you feel that restriction or that tightness, and then helping them understand, like, that's okay. We don't want you to just live with that and ignore it, but I want you to be able to do these things that we know have helped you in the past. If you do those things and it doesn't help you, then that's when I would say, come on back and we'll check everything out.
Oh, that's awesome. This has been really informative on just the recognition of what hypermobility looks like and the different faces of it. What would be your, 3 key things that you would want people to take away that they can, implement in the clinic right away?
Yeah, so I think one would be just to start looking for it. Like, you want to be able to find it, and you want to be able to help educate your patients about it. You want to be able to empower your patients. So while it's great if you can get rid of their pain or their problem in the clinic, you want them to know exactly what to do at home. And some of those things we talked about. Isometrics are a great option for these patients. The research supports isometrics are awesome. They're a lower load on it, and it just tends to be good for that patient. And then also just giving them the knowledge that they need, that this is maybe not exactly typical where they look exactly like the person next to them, but that it is normal for them. And it is 100%. They can, do what they want to do. They can be able to go do their sport, do anything they want to do in life, and it's not going to hold them back. This is not a negative thing. This is just what they have and what they have to work on.
It's not a negative thing. It's just their thing.
Yeah, everybody has their thing.
Everybody has a thing. So, okay, this is awesome. We could go so much deeper. We really went into the identification of it. I would love to go into some, deep dive into treatment strategies, what works when, from a manual therapy perspective, what not to do, what to do, and then therapeutic exercise perspective. But that would make this episode a couple hours long. So are you willing to come back for a part 2 where we can dive into that?
I would love to, because I think it's so many small changes that make such a big difference. And it's really exciting. Like, this is a population where I feel like you can fall in love with, even if right now you're like, I have no idea what to do. It is exciting. And you get to be that person. Again, this is somebody that may have gone to 8 to 10 people and been dealing with this for 7 years. And you're going to get to be that person that helps them and helps get them to their big goals. And it's the coolest thing when it happens. So I would love to come back. I would love to talk about that.
That's awesome. One of the things I like to ask at the end is, you certainly bring a great amount of experience. What would you say to yourself if you could go back? We won't even say how many years, but if you could go back, what would you say to yourself? What advice would you give to yourself back in the day?
If I could go back and give myself more advice on like what I should do, it would be to listen more to what people are telling me rather than immediately trying to solve their problem. So I think with this group, a lot of times they've either felt like they've told their story, or they felt like, they were brushed off, or they didn't respond to it. And I wish I could have told myself, like, if I had just sat back and listened to like the individual in front of me, I don't think it would have taken me until I had like an entire team where I started to recognize patterns. I think I could have possibly picked up on some of the things that they were telling, the tightness that didn't add up, or, the weird bruising or things like that. But I would want to go back and tell myself just to listen, and then to be able to respond, getting all the information, not trying to put them into a bucket immediately.
Oh, that's awesome. That's awesome. Well, this has been such a great show. Really enjoyed speaking with you and having this great conversation. How can people get in contact with you, or if they want to connect with you?
Sure. Email is probably the best. So Jenna Gourlay @gmail.com. People will also shoot me a DM on Instagram. I think my handle is @Jenna Gourlay. Either way is totally fine. I'd probably say I'm better at email than anything else.
That's fantastic. Awesome. If you want to connect with me, feel free to do so at philplisky.com, and certainly on all those social media channels. Jenna, it has been so great. That's all the time we have, but looking forward to our next episode.
Definitely. Thank you so much.
Fantastic. Well, thank you everyone for joining us today as we continue to build the future of rehabilitation and performance together. Thank you for tuning into this episode of Rehab and Performance Lab by MedBridge. Please be sure to subscribe and listen to more of our episodes on Spotify or your favorite podcast platform, and at medbridge.com. If you're listening outside of the MedBridge catalog and would like to access the bonus resources and receive continuing education credit, simply log into your MedBridge account and search for this episode to find the accreditation details. Rehab and Performance Lab also listens to you. If there's a particular clinician that you'd like to hear from, or if you have a clinical question or a challenge that you'd like to see addressed on this podcast, please let us know by leaving a comment on our Instagram post or by emailing podcast@medbridge.com. See you next time.